Telemedicine is making a very positive contribution to healthcare during COVID-19 pandemic and is being used in a variety of ways. It bridges the gap between people, physicians, and health system digitally, enabling everyone, especially symptomatic patients, to stay at home and communicate with physicians through virtual channels. What is the roadmap of telemedicine in India? What is the role of emerging technologies in healthcare, especially artificial intelligence? Moderator Mohd Ujaley, Senior Special Correspondent, ETGovernment, will take this conversation forward. Over to you, Ujaley.
Hello and welcome to ET Health World Innovation and Intelligence Healthcare Summit. In this special fireside chat, focus on strengthening healthcare delivery system in pre and post-COVID pandemic, evolving role of telemedicine, e-health and m-health. We'll focus on the role of telemedicine during health emergency and how actually government organization across the country has responded to this pandemic. Also, we'll try to analyze the role of emerging technologies, especially AI, machine learning, or any technology in healthcare, especially the AI. We'll try to understand how actually AI could be used for improving the healthcare outcome. To lead this particular fireside chat, I'm joined by Major General AK Singh, President, Telemedicine Society of India, and Dr. Dinesh Tyagi, Chief Executive Officer, CSC E-Governance Services India. Let me begin with Mr. Singh. You are the Telemedicine Society of India. Would you like to share as to how the last 4 months, especially the pandemic, the lockdown was announced, what kind of innovation you have witnessed in last 4 months, especially around the use cases of telemedicine?
On the 25th of March, when this was announced, the TPG was announced, the Telemedicine Practice Guidelines were announced, the TSI was put its foot down and started running straight away. The aim of our the TSI was to sort of train doctors to understand what TPG was all about, what telemedicine practice guidelines were all about. And we started off and we curated content, we curated a curriculum, and we started training doctors. We have so far trained about 300 doctors, 3,000 doctors to be precise. The only innovation that I have now started seeing is initially we thought it would be just a sort of a room where we would set up a telemedicine center and carry on, but that was not true. When we presented our PPT to Dr. Vinod Paul, he said, "What are you doing? This is no longer the thing. Now it is M-Health. It is mobile is going to be the source where a patient can contact a doctor. So you have to start training them accordingly." So that is what one thing which I noticed was suddenly mobile became a very hot property and people who had smartphones could easily contact the doctors. Doctors were using mobile phones, they were using WhatsApp, they were doing everything, but now it became legalized. So we had to train them and tell them what legal issues were. Right. These were things that we did.
Right. I'll come back to you, sir. Again, now I'll move to Dr. Tyagi. Dr. Tyagi, you run this common service center, and the common service centers are spread across the country. And telemedicine happens to be one of the integral part of the CSC service delivery. And I know in the past, e-Pashu Chikitsala and other experiment you have done. Would you like to share as to how the last 3-4 months were for you from telemedicine point of view?
As you said, common service centers largely caters to the community or the citizen who live in rural India. And the need for telemedicine is actually more profound for these segment of society. Even in normal circumstances, it was difficult for them to get a good healthcare service available. So we started these telemedicine, what called teleconsultation with doctors. We started with one of the topmost hospitals in India, and they provided some doctors and they were doing consultation wherever it was required. We also know that teleconsultation or telemedicine is a replacement to an existing system of quacks and other formats. So it's not easy to break the nexus which is existing, even in rural India for that matter. So we were prepared that it's a long-term journey, and it's going to take longer period for us to assimilate teleconsultations part of process for extending healthcare to rural India, and that's why we started. So if and the actually the opportunity through COVID has been significant. COVID has brought a new way for teleconsultation acceptance and assimilation within the system, both from the doctor's point of view, who were earlier reluctant to do teleconsultation or unwilling to do so, and also the citizen who was also not confident that teleconsultation can be a process for healthcare for him. So both the aspects, the COVID created this opportunity for both the segments of both the segments, and helped in promoting teleconsultation. For the numbers, we were earlier, the last year, we did the figure of about 66,000 teleconsultation across the country. But you'll be surprised that from April to till date, we have done 208,000 consultations. So which is significant in terms of what the numbers are. And we do all forms of medicine. The advantage is we not only focus on one, we also focus on allopathy, Ayurveda, and homeopathy. So we give the choice to the citizen, whatever we do. And there are phenomenal stories in rural India who's got benefited by this process. So we are presently doing it in large scale, and we do believe that with some more inputs on electronic diagnostic, and the dispensers of medicine, both will try and help us. The regulation which is brought by the government of India presently, of course, has given the momentum for us to try and expand and bring in more doctors into our platform.
Mr. Singh, I'll come to you. How challenging is the connectivity part? Because telemedicine primarily lies over connectivity. And in the rural areas, despite the fact that CSC, other agency, and at the panchayat and gram panchayat level, people are trying to actually bring some level of network connectivity so that digital services could be provided. But we are still far away from the kind of connectivity which is needed to provide a quality service. What is your assessment of this connectivity challenge as the president of Telemedicine Association, and how challenging this part is to basically proliferate telemedicine across the country?
I am right now sitting in my village, which is about 22 kilometers from the nearest center. That is our community health center and the medicine thing. And I'm sure I'm very visible. We have a geo tower here. We have 4G connectivity. And believe it or not, all of the kids here are seeing movies, they are streaming videos, and there is no issue. Now, somewhere, if I want to, at the actual ground position, little different. In my village, there is no corona. There is no COVID situation. It's been there for the last 4 months, and the people are very guarded. They move around without mask, that is one. And the Jhola shop doctors have had the best of time. There are 2 of them. They have a motorcycle, and they attend to the people at home. So it is doorstep delivery.
Right.
Connectivity, I've been trying to convince that guy. There are 2 of them. I talked to them. I said, you guys are going to land up in trouble. So they say, Babu Sahab, pardon my Rajasthani language,
Right.
Babu Sahab, these people deserve some, better healthcare. Hum karte hain, we go there.
Right.
We've got a pharmacy shop here. So, believe it or not, from the government side, we have a sub-center. And the government side, what they are doing is collecting data on maternal child health. They are doing nutrition, they are doing something, but they are doing nothing about COVID, nothing about telemedicine.
Right.
And people like us are reaching out in villages and trying to convince them that it will be great, because it's saving to the thing. Now, one thing before I finish, the buses stopped from here because there was no buses and it was total lockdown. And believe it or not, these Jhola Shop doctors came of great value and they were really handy here. Right. So that's it. So connectivity is no issue. People are willing to sort of take help of anything that comes their way. So telemedicine is bound to succeed.
Dr. Tyagi, what Mr. Singh is saying, there is a low level of awareness, despite the fact, some of the villages do have a good connectivity because of certain telecom provider are going across the country. They are creating, telecom network towers. So there is an awareness challenge. What I believe that there is also a kind of, experience, the sympathy or empathy part when you meet a person, talk to them, and then actually he advises you something, so you are bound to believe. That kind of empathy is possibly a bit tough to get on a virtual platform. So how do you look at this challenge?
Of course, what you said may not hold valid for many, because we have seen large number of women, especially in UP, who have never gone to a doctor in their life, and are, even if they go to the doctor, they're not able to tell the actual part. They are hesitant. They don't tell all the problem which they have. But on a virtual doctor, they open up. They speak for about 15 minutes and do that part. So the virtual part actually created more confidence in them. Once you're right that as individual, as standalone, it will be difficult for them to do themselves. They need an assisted format. That's why the Common Service Center. Common Service Center provides the technology framework, build the confidence in them that you are safe here. You can talk to the doctor, and the doctor is also in a platform available. Will not do any. He's not jhola tap. He jhola chap in that sense. He's a recognized medical doctor. That helps quite a lot. One or two issues, which is, of course, the connectivity in 6 lakhs villages still continue to be one of the challenges. Not all 6 lakhs villages have good quality connectivity. And with BharatNet, probably these things will get sorted out. With BharatNet expansion now, in 1,000 days, both the Prime Minister said that 1,000 days, every village, means more than 6 lakhs villages will get Bharat fiber, optical fiber. This problem will get resolved. Once this is resolved, the second issue is when they talk to the doctor do a prescription. Prescription, they say, if I have to go to town to buy medicine, then why not go to town to talk to the doctor? So if you can do this e-pharmacy, that even the medicine can be procured, you can place an order, and there are courier services on a prescription basis, they will send you the medicine. So you can get medicine. Plus some diagnostic. If I can do some HP or blood test within the same local. So if I can do some diagnostic, some dispensing of medicine, and a teleconsultation with the option, that we can create model. And it will happen. It will take a little time for the community to assimilate, but I think over a period of time, all these what was told jhola tap will disappear. They won't survive for a long time.
Mr. Singh, we know that in last 2-3 months back, government did approve, actually did, some regulation tweaking and allowed actually a lot of things to happen, which were highly needed, and, telemedicine practitioners were requesting since long. But overall, in a framework, what we are noticing that we do have a green shoot of a good telemedicine service provider here and there. But on a national level, we don't see, despite the fact that we do have a framework in place, but we don't see somebody actually leading it. For example, you do have a digital India sort of thing, so there are organizations which is doing it. Can we have something around, such kind of a push from a central government, maybe from a central agency, so that, you are able to create the awareness, number one. Second, there will be adoption also. Even especially the MBBS doctor will come on the board, and they will be incentivized in some way. There will be a benefit for everyone.
I think that's a lovely idea, because I've been talking to a lot of people, and especially government people. The Telemedicine Society of India has got 12 chapters, state chapters all across India. And we are creating sort of awareness. But what is actually required is a massive campaign, especially with the youngsters, with doctors who are sitting there. In my village, there are a lot of people who are now unemployed. They're sitting there, they're doing a lot of things. So they are IT savvy, they are computer savvy, rather they're laptop, mobile savvy. So it's a very good thing that can happen. But the first thing that you need to have is awareness, and a blitz of awareness, in the sense the way the immunization comes out on the TV. A very small program on telemedicine would be perfect. Because right now, individual efforts have come in, and there are a lot of fly-by-night operators who are coming in. They're doing the thing and do it. We've had a number of webinars with the rural India. And in rural India, in GST, they have a telemedicine slot. When they file GST, there's a telemedicine slot. CSC, there's a telemedicine slot. And we had I think, lots of years back, there was a big organization which took over 1 lakh CSCs. And I, being with the TSI, I also wanted some people should take on this role of telemedicine. When we went and approached these people who operate e-mitras and CSCs, the first thing they said is, "Sir, it takes a lot of time, and what we get is 40 rupees. The doctor who's available may not be available at that particular time." Right. So things have to change. System has to come into this thing. A process is required. Mm-hmm. So that is what we are looking at, and we're looking at the government to sort of help us do this. Right. And we are in a position to do it because we have another 2 chapters coming up. Gujarat is coming up, Northeast is coming up. So definitely there is a central pushes which is required, which Dr. Tyagi and partner are doing, but right. They have to tie up with some people like us who are on the ground.
Dr. Tyagi, one thing is that, CSC is doing a lot of work. Telemedicine happens to be one of them, and there is a green shoot, there is a good work also. Some use cases are also there. How we can actually take it to the scale which is really needed, especially what Corona has done. Corona has enabled us to believe on the technology, and technology has allowed us to proliferate a lot of things. And even at the government level, decision making in terms of the big project for the technology has become quite easy. So how we can do that? For example, Mr. Singh was saying about, many a times that qualified doctor might not be available for consultation. So there is a shortage of a qualified doctor at the rural level, also at the district level, primary, tertiary and secondary level. How can we address this thing?
If you really want to succeed in the teleconsultation, telemedicine, and keeping in view the various problems and constraints that exist in rural India, right. Telemedicine has to get integrated into the normal OPD format.
Right.
Unfortunately, that has not happened. With all respect to doctors, they're still unwilling to take this as a virtual OPD. They still think this is an additional burden on them. And that's why they approved it. A virtual OPD is basically reducing their workload. And we approved it in the state in Tripura. When we did the program, we showed to the doctor that your workload has phenomenally gone down. The long queue from his OPD has gone down. So that culture of the doctors accepting telemedicine part of virtual OPD means OPD, one patient will come physically, one patient will come on the TV or on the screen, and both are treated simultaneously. Then it's a great story. Then it makes sense, because then the doctor's availability and acceptability is also very high. Local doctors will be available, whether from the PSC or the hospital, wherever the case may be, and they will speak local language and understand local nuances of treating diseases. So this issue of assimilating within the OPD framework of the medical system is going to take a little time. I think once that is assimilated, things will get sorted out. So I'm sure all the issues get resolved, right. And the people will have more confidence, because he will talk to the same doctor whom we go and meet physically. And he has no problem in getting the acceptance of this.
Right. Mr. Singh, in oral conversation, what we can make out that doctor is a very important and integral part of entire ecosystem for this telemedicine, and they have to be on the board. Many a times, if you look from a doctor's point of view in India, many a times those are highly burdened up. They already have cases within their hospitals, and also the platform, the existing platform to do, let's say, video conferencing, telemedicine, are not as friendly as it should be. For example, we are doing something on the Zoom, it's quite easy. So that means we need to invest into technology, which is our platform. We should create a platform which is highly user friendly. Just you click couple of buttons and you are live and you are able to talk to the people. So in that light, what kind of role do you see technology like artificial intelligence, machine learning playing in it?
Government of Rajasthan had a PPP model, or telemedicine service providing, right. And we were part of it. And we have about 20 telemedicine nodes sitting in our hospital in Jaipur. It is Mahatma Gandhi Hospital, which is in MGMST Sitapura. Right. Now, this PPP model person had 150 nodes all across Rajasthan. And there were nurses there, that is paramedics there, and they presented it. Now, we ran that for about 2 years, and we realized one thing, that there are certain specialties which require a lot of, which will be very good for telemedicine. One is dermatology. Right. And dermatology also has, it's a very simple thing. It's an image that you are seeing. It is an AI model which I have now interacted with at least 2 or 3 doctors who are making AI and MLM coming up. So when we do that, so this is there we have all learned. One is what you call dermatology. The second thing that we saw were orthopedic cases.
Right.
Orthopedic cases were tremendous. Now, from that position where there is a telemedicine node, the hub has shifted to the patient.
Right.
Or to a doctor who has, or a paramedic who moves around in the village and he talks to the patient and the patient says, so that's a little challenging.
Right.
There is a thing which has come out by the government. It's a OPT based model, but the thing is that it works 8 to 2. Right. And now I'm sitting in my village, 8 to 2, I don't see a person here because they are all in the fields. Or even the ladies go to the field. So it's a very challenging task during this period when there is a lot of things available. So what I feel is that it is a very good thing, but it will take time. And the ASHA workers, the sub-center workers, they have to be trained. They already have a tab where they put in a lot of data. It's a little apprehensive that they may take on. But the ground reality is that today in my village, right, the only telemedicine thing that we do is me talking to people at my hospital.
Dr. Tyagi, one of the key reasons for success of any platform, any services is that the proper incentivization of all the stakeholders at different level. For example, even in the CSC, whether it is a VLE or the platform itself, they are properly incentivized. In that light, what kind of incentive we can offer, and possibly the government from the policy point of view can bring in to ensure that people are aware about the benefit of telemedicine, and they are able to rely on telemedicine, and then you are able to reduce the number of OPD visits across the country.
Telemedicine commercially is not viable.
Okay.
That's a fact. And that fact is to be recognized, that it is very difficult to build a commercial viable system for telemedicine, because people in India, especially in rural India, are used to the free. If you ask them to pay some money, or they will not pay so much as the cost is, the cost of the doctor and the cost of the infrastructure which somebody has set up for them. Both are significant. Also the internet cost. In rural India, internet cost is also fairly high. The successful models for telemedicine, if you want to really look in India, is the Arvind Eye Care. That is the best story. In fact, one should, telemedicine started with Arvind Eye Care. They are the pioneer in doing it, but they are forgotten because they're looking only in the eye. And these centers are integrated with their OPD. And they do all the hand-holding for them, including the glasses we made, and do that part. Eye is also safe because every photograph of every disease of the eye can be identified through a photograph. So that makes life easy for the doctor. Dermatology, eye care, artificial intelligence can play a significant role. The state has to support financially. State and the government has to support these nodes or these private enterprises which are now building the network and trying to help the citizen so that it makes commercial sense to them. If it doesn't make it, it's a social enterprise, not that they should make too much of money out of it, but they should be able to bring their cost. At least somebody said, okay, it takes too much of time for him to do a teleconsultation, all that part. One is, of course, the availability of doctor on time when he needs, day, night. Fortunately, we have private doctors. We don't have only government doctors. So they're available 24 hours, whenever you want, as per the availability. Doctor shows the availability. The second is the incentive for him. What is the incentive for that person to help somebody to do this transaction? That's what presently we are doing at 1 rupee consultation. We do 1 rupee and we pay out of our own and trying and building a system so that once the confidence comes, then probably citizens start paying it. First time, very difficult to charge money.
Mr. Singh, on the incentivization part, given the fact that you run an organization whose job is to primarily promote telemedicine across the country, and you have started many chapters and 2 more chapters are in the pipeline. So from a challenge point of view, I mean, we discussed about like the connectivity challenge in terms of the government support. I mean, incentivization is really important. Do you have any view how actually we can incentivize doctors so that they feel attached to telemedicine? They come to the point?
Well, I have an organization which we have valued and we have evaluated, and now they are putting up, they have about 200 clinics in UP, and the cost of a telemedicine kit is about 25 to 26,000, and their charges are very simple. They have about 3,000 doctors on the panel. The doctor, rather the guy who's operating the operator, he gets about 40 rupees per case. The doctor gets his fees. If he's an MBBS doctor, the total fees is 100 rupees. And out of this, 40 goes to this person who's the operator, and 20 goes to the person who's providing the solution. Right. And the doctor gets the rest of the money. Now, it is working. Right. Well, if from my village, someone has to go to 20 to 25 kilometers away, the first charge is 30 rupees. He can't go alone. He has to take someone along with him. So that is 60 rupees. And coming back, it is another 60 to 120. Economic wise, the patient gets money in his pocket. He doesn't have to spend anything. Now, sitting here, if I can get 100 rupees worth of a doctor sitting in that 25 kilometers away from me, I have saved at least 50 to 200 rupees. So it is going to come. Commercial things have to come. Without commercialization, nothing. Where we are so used to free treatment that it is pathetic. Right. Everything is wanted in goli do, nahi milega. It will not work out. Absolutely. So even the Jhola Sahab doctor, believe it or not, one IV thing he puts, he charges 100 rupees. So people are paying for it.
Can we also experiment in telemedicine, for example, some of the diseases for early detection, or maybe, under the Ayushman, under the Ayush ministry, there are a lot of things which is being promoted, and wherein you don't require, very highly qualified MBBS doctor to look into it. So maybe at the earliest stage, can we do something?
Definitely. I am starting a project from Mahatma Gandhi Medical College in Jaipur. It's basically a retinoscope which we are purchasing ourselves, and it is early detection of diabetic retinopathy, which is going to be a major. We are supposed to be the capital of the world in diabetes. So it doesn't require a doctor to go there. It just requires a van which goes to the places. We have to know that anyone who has diabetes, come in, check your eyes, check his blood sugar. People are now very aware. These Jhola Sahab doctors have kit which is available. They check it and they tell you, Sahab, itna blood sugar hai. Yesterday I got it tested. So these things are there. Dermatology, we are going to start off. We are going to start off with a retinoscope. Now the thing is, the government has to support on this. If they give us a retinoscope, which is there are a lot of retinoscopes which are coming in the market. We have followed Arvind eye thing. We are also following the Shankar Netralaya thing. So the government has to give us give a subsidy on the retinoscope. We'll take it on.
Dr. Tyagi, one thing that you very rightly mentioned, that the pricing of these services has to be attracting for a different stakeholder. But we also know to the fact that you can't have a pricing which is prohibitive. I mean, rural India has some challenge. They can pay to a certain amount. That means your pricing has to be quite affordable for telemedicine services to be adopted and accepted by people. What kind of innovation in pricing we can bring in, so that at least there is some level of adoption where people are actually starting side by side with their main practices?
See, what the telemedicine is doing in the private system, they're only helping the state to achieve larger objectives. They're also reducing their workload, which happens in the normal healthcare system, whether it is sub-center or the PSC or the hospital. So the state in any case is reducing its expenses by enabling telemedicine being done in the rural India by somebody who's an entrepreneur. So that cost, which is the cost reduction, can be shared in whatever format they want to share. They may make it available, or as doctors have it, they can give a diagnostic kit at some price to him so that he can do that part of the work. It has to evolve over a period of time. The pricing structure will evolve. Plus, there are a lot of organizations who should do CSR funding initially. See, it's like the tea. Initially, when the Englishman gave the tea, he gave free. Absolutely. Then now they pay 10 rupees. Some places they pay 20 rupees. So the tea is also. So you have to get this culture of people initially accepting this as part of their life. As I said, I need not go anywhere. I can sit here and get my advice. At the point you said, Ayush Ministry and Ayurveda and homeopathy are the best for us. We do large homeopathy because homeopathy is safer in our sense. In fact, many people question why we are doing homeopathy. For me, the risk is very less compared to कोई मीठी गोली खाने से मरता नहीं है. There, nobody dies with meठी goli. And let me tell you, the large number of people, especially these white spots on skins, people will have problems with that format, and all those has been treated. There are a large number of people who have got treated in our system by using homeopathy. Even for the COVID time, about 1 lakh kit for immunity development. 1 lakh kit of homeopathy has been sold through the CSC for immunity development. That is the homeopathy. So homeopathy looks safe for me. We start, once they get used to it, then they can also do allopathy, depending on. And we're not taking the serious disease. We only do diseases which are preventive in nature. We do only dengue, malaria, fever, cough, cold, and these kind of diseases can be treated, or skin infection, which is so simple to do. If there are heart problem, heart attack or something, he is referred to the hospital. We tell our people that please don't treat serious patients.
Absolutely.
Telemedicine is not for serious patients. Serious patients is sent to the hospital.
Right.
The entire system will get if something happens to them, the entire system get affected.
Dr. Tyagi, Major General A.K. Singh, for sharing your views on the roadmap for telemedicine in India and what kind of role telemedicine has played in last 4 months, especially after the announcement of the lockdown, the kind of challenges telemedicine is facing in India, including the connectivity part, incentivization part. Thank you once again for being such a wonderful friend. Thank you so much.
Thank you, gentlemen, for such a unique perspective to the conversation. I would like to bring to your notice the exhibition booths at the expo area are definitely worth a visit. So make sure you check out Dell booths to know more on reinventing business models. Stay with us for the next session.